मैम रिकॉर्डिंग ऑन हो गई, आप माइक कैमरा ऑन कर लीजिए।
Hello, everybody. Hi. So, मतलब I'm having a very bad throat अभी मेरा गला खराब है बहुत ज़्यादा, so थोड़ा सा पढ़ाना आज मुश्किल होगा, okay? But we'll have some, but I have prepared some resources, okay? So that we can have, go through our class and you can have a better understanding. मेरी कुछ आवाज़ आपको समझ में आ रही है, नहीं आ रही है?
यस मैम आ रही है, बाकी आप चाहो तो नेक्स्ट क्लास में अभी नहीं बोलना।
क्या बोला हर्ष?
यस मैम।
हमारी आवाज़ नहीं आ रही है हर्ष।
पावर ऑफ।
अभी आ रही है मैम?
अभी आ रही है, बताओ।
समझ आ रही है, बाकी अगर आप कंफर्टेबल नहीं हो तो फिर हम कल परसों में क्लास देख सकते हैं, ऐसी कोई दिक्कत नहीं है।
अच्छा नहीं, मतलब मैं कंफर्टेबल हूँ, डोंट वरी। आई हैव प्लान्ड कि हमें कैसे करना है नॉल, ठीक है? सो वी विल कंटिन्यू अभी। सो व्हाट आई विल डू इज दैट आई हैव सम कंटेंट विद मी, ठीक है? आई विल शेयर दैट कंटेंट विथ यू, ओके? एंड जहाँ पे मुझे भी थोड़ा कम बोलना पड़े और यू गाइज ऑल्सो हैव अ गुड ईयर, ठीक है? गुड अंडरस्टैंडिंग। सो दैट ओके। I'm sharing my screen. So abhi this is like so I have here like the entire short roadmap of your course. Okay. So I've tried that. Suppose if I cannot speak, I'm the teacher and it is difficult for me to speak. What we can do is that there are a lot of resources. और मैं ये आपको कोर्स इतने टाइम से पढ़ा रही हूँ, ठीक है? I've been teaching this for since long time. मैं आपको ये वाला पढ़ा रही हूँ, बता रही हूँ. So you already have an idea कि मेरा क्या thought process है, कैसे करना है. So now we look around, okay? We look at other perspective. ठीक है? Get to know. We'll watch some news clips. We'll watch some videos and we'll okay. जिस चीज के बारे में हम पढ़ रहे हैं, जिसका अभी हमने we have completed the syllabus. All that we have known and all that we have studied, how relevant it is to you guys, okay? सर मेरा पर्सपेक्टिव जरूरी नहीं है ना, दुनिया में और भी लोग हैं और भी हैं, तो all those perspectives. So for that I have collected videos, okay? And we will be watching those एक एक करके, ठीक है? So the class I will end in 1 hour, 1 hour sometime, half an hour, 1 hour, half an hour. But it will be beneficial for you if you stay, okay? So let me share my screen again. हर्ष मुझे कंफर्म कर वो वीडियो की आवाज आ रही है या नहीं?
Every year, 5 million Indians need a heart surgery.
ठीक है, ओके. सो यू सी कि यहाँ कैसे मैं अपने लेक्चर्स कहाँ से प्रिपेयर करती हूँ एंड व्हाट इज दिस.
to survive, but only 3 lakh of them, as in only 12% of these patients get this surgery done. Well, the rest 88% of these patients are either forced to wait, suffer, or they have to hope for a miracle to happen.
India has the highest number of people with heart conditions in the world. The majority have no chance of survival because their families are unable to afford an operation.
Healthcare doctors are not available, facilities may not be available, and people may have less money.
A country where 80% of all medical bills are paid out of pocket.
So what you see is not a health problem only, it is an economic problem.
But the question is why? Why is this condition so bad? Well, do you realize 90% of the Indians make less than 25,000 rupees a month? And imagine earning 25,000 rupees a month and you are handed a bill of 3 lakh rupees for a bypass surgery. For most Indians, this isn't just expensive, it is impossible.
Every day, I see about 60 to 80 patients in my clinic. Most of them are little kids sitting on the mother's lap. I examine the kid and I tell the mother that your baby has a hole in the heart. He needs an operation. She has only one question. You know what that question is? How much it is going to cost?
ये मैंने आपको क्लास में भी बताया था और ये बात उन्होंने बहुत जगह बहुत सारे इंटरव्यूज में बोली है. This was his one really motivating factor because of which he started Narayana Health, and we'll see how it works.
Secondly, India has a capacity problem. In a country of 1.4
And remember, it's not a health problem, it's an economic problem. Remember that line.
billion people, India has the capacity to perform just 3 lakh heart surgeries annually. So what's the next option? Well, it is to go international. And if you go out, the prices don't increase by 2 times or 10 times, but by 30 freaking times. In the US, the average heart surgery cost in 2021 was $123,000. You know how much that is? That is approximately 95 lakh rupees. But you know what, guys? One Indian did something so revolutionary that he built a hospital that could conduct free heart surgery while making a 400 crore rupees in profit. I repeat, free heart surgeries for thousands of people all across the world while making 400 crore rupees in profit. And today, the whole world is recognizing his genius. This man goes after the name Dr. Devi Shetty, and the hospital that he built is called Narayana Hrudayalaya.
Narayana Hrudayalaya, the temple of the heart.
We call the Henry Ford of heart surgery.
Hospital with a difference, determined to make a difference. To some, Dr. Shetty was either a crazy visionary or perhaps just crazy.
For me, heart is the center of the universe.
So we created Narayana Hrudayalaya and Narayana Health group of hospitals about 20 years ago with the idea of democratizing high-tech healthcare.
Dr. Shetty operates on more than half of his patients for nothing.
So if the parents are not in a position to afford the high cost of heart operation, and if the babies come to us, we have to do the operation whether they have money or no money.
The question is, while most hospitals charge lakhs of rupees and still remain small, how on earth did Narayana offer free heart surgeries and that too with a 400 crore profit? What are those revolutionary processes that turned it into such a remarkable case study for the Americans to study? And most importantly, what are the lessons that we need to learn from the extraordinary work of Dr. Devi Shetty? Before we move on, let me thank Ditto for supporting our content. People, as we all know, healthcare costs in India who can explain the policy in simple English, help you with steps in to help you out. The best part is presented with the scenario and data of 2011 and understand these models better.
If you want to learn Kathak with just easy to follow once a week sessions and be a graceful dancer, please check out
People, the secret to Dr. Shetty's success lies in a game-changing business strategy that flips the traditional hospital model on its head. Let's break it down. You see, most hospitals aim to save costs by hiring freelance specialist doctors instead of full-time doctors. And these freelance doctors are paid on a commission per surgery basis. So let's understand this using an example. Let's say a hospital performs 8 cardiac surgeries per month. Now, this hospital has 2 choices. Now, mind you guys, none of these figures are accurate because the case study data is from 2011, and these numbers are only meant to help you understand the concept and not to tell you how much the doctors are exactly paid on a per surgery basis. So let's get in. Let's say there is a hospital that performs 8 cardiac surgeries per month. Now, this hospital has 2 choices. Number 1 is to hire a full-time doctor at a salary of 6 lakh rupees per month, or they have the option to get a freelancer by paying him 50,000 rupees per surgery. Now, if the hospital opts for freelancing, they pay 50,000 rupees into 8 surgeries equal to 4 lakh rupees. So if you look at the numbers, freelancing seems like a smarter choice, right? Because the hospital saves 2 lakh rupees per month as compared to hiring a full-time doctor. But here's the twist. This demand-driven model only works when the number of surgeries is limited. And here's what happens if the hospital's surgeries increase to 15 per month. Using the freelance model, the hospital has to pay the freelancer 50,000 rupees into 15 surgeries equal to 7.5 lakh rupees. So if you see, as soon as the number of operations increases, the cost of freelancing surpasses hiring a full-time doctor. So it becomes more expensive and less sustainable as demand grows. And here's where Dr. Shetty saw an opportunity. He thought, instead of limiting the demand, what if he could create demand? And he landed on what was a gold mine that did not just mint money, but also change the lives of millions of Indians. And this is something that the entire world applauds him for. So here's what he did. He hired full-time specialist doctors and he built a system where they could perform a high volume of surgeries. And here's how the brilliance of this model is reflected in the economics. Like we saw in the intro, in India, only about 12% of the heart patients can afford a surgery, which leaves an untapped market of millions of patients in a dire need of heart surgeries. And these patients do not get a heart surgery done because it's too expensive. So let's say 10,000 people can afford a heart surgery at 3 lakh rupees. But if this cost of 3 lakh rupees goes down, more people will be able to afford it. For example, at a 2 lakh rupee price point, 30,000 people may be able to afford it. And at 1 lakh rupees, 50,000 people may be able to afford it. So Dr. Devi Shetty thought if he brought down the cost of heart surgery from 3 lakh rupees to 2 lakh rupees, the number of patients coming into the hospital will shoot up. And if the number of patients shoots up, then the number of surgeries will shoot up. And if the number of surgeries shoots up, he can bring in full-time heart specialists. And these heart specialists can work on a salary. For example, instead of doing just 8 or 10 surgeries per month and paying the freelancer about 4 to 5 lakh rupees a month, Narayana Health created the capacity to perform 30 surgeries per month for every single doctor. And he paid the doctors higher salaries than what an average freelancer would earn. So let's say Narayana pays a full-time heart surgeon a fixed salary of 7 lakh rupees per month. So if you see, it's higher than what an average freelancer would earn at about 4 to 5 lakhs per month. But now, instead of performing just a few surgeries, the hospital builds the capacity for this doctor to operate on 20 patients a month. So now the cost per surgery for this doctor who's on a salary would be 7 lakhs divided by 20 surgeries equal to 35,000 rupees per surgery. Now here's the brilliance. When the per surgery doctor cost drops to 35,000 rupees, the total cost of the operation goes down. And when Narayana Health deployed some game-changing equipment usage efficiency, the total cost of the surgery, including other expenses like hospital facilities, could be reduced from 3 lakh rupees to around 1.5 to 2 lakh rupees. And like we saw, at 3 lakh rupees, if 10,000 people may be able to afford it, at 2 lakh rupees, 30,000 people will be able to afford it. And as the price drops, more and more patients will be able to afford it, which will lead to higher patient inflow. And then
this is exactly what we discussed in class, higher patient inflow.
The hospital can maintain profitability while making surgeries accessible. This is how Narayana Health leverages a high volume, low cost model to address affordability while remaining financially sustainable. So if you see, at the end of the day, the doctors at Narayana earn more than what a freelancer can earn. Number two, the cost of operation goes down, so more people are able to afford it. And because of economies of scale, Narayana Health makes a healthy profit. This is how the supply-driven model revolutionized healthcare in India and proved to the world that compassion and profitability can go hand in hand. And this brings us to the second point, and that is, how did they achieve economies of scale and maintain the consistency and quality of the operation? Because most people would think that as the cost of the operation goes down, the quality of the doctors may also go down. But here's where, ladies and gentlemen, Dr. Shetty used such a smart model that even the American doctors were shocked, because as the number of operations increased, the cost went down and the quality of the operation also increased. And another reason why the Americans were shocked was because they saw
कुछ कह रहे हो हर्ष? You're saying something क्या? आवाज आ नहीं रही है. You can raise your hand or you can write in the chat box अगर कुछ कह रहे हो तो. हाँ बोल.
आई कौन? आई थिंक मैम कुछ.
Okay.
that Narayana surgeons were so efficient that while an American doctor does only 100 to 200 surgeries a year, a Narayana surgeon does about 400 to 600 surgeries a year. The question is, how is that even possible? Well, to explain this, instead of using too many technical terms in the heart operation procedures, let's understand this using the restaurant operation and the making of a biryani.
I didn't think a strapless
Very
bodysuit could do this.
I
Tried
would
way too
want you
many.
to-
They all lied, but
Yes, you heard that right. We are going to understand how Narayana made heart surgeries more efficient using the example of a restaurant and the making of a biryani. So let's get started. You see, the assembly line for surgeries at Narayana Health is divided into three parts. Pre-operative procedures like test and anesthesia prep, and then comes the surgery itself, which is divided among senior surgeons, junior doctors, and skilled nurses. And then comes the post-operative procedure like monitoring and recovery support. And if you look at the biryani masala preparation, you again have a very similar set of procedures. There is a pre-operative process like collecting ingredients, roasting the spices, and grinding the spices. And then there is the main operation where all the ingredients are perfectly put into a mix and the masala is prepared. And then there is a post-operative process like cleaning and organizing of tools and organizing the leftover ingredients. So now if you look at a restaurant, does the head chef go and buy the spices and clean the utensils? Not at all. These tasks are divided between a set of juniors, specialists, and one super special head chef. And here's how the kitchen would organize these tasks for efficiency. The kitchen staff first procures the vegetables, spices, knives, spoons, and cookers, and they clean the tools and the workspace to keep the kitchen ready for operation. Similarly, they handle all repetitive and preparatory tasks. So the time spent by the junior staff is around 2 hours. Then comes the sous chef. The sous chef collects and preps ingredients to ensure that they are clean and they are ready for roasting. Also, they operate the grinder to prepare the masala ingredients. So the sous chef might spend an hour into this operation. But after everything is done, what does the head chef do? The head chef only oversees the operation and comes in only for the core process of mixing the spices and all other ingredients to ensure that the final masala blend has the perfect balance of all the flavors. So the head chef barely spends half an hour in the process of making the masala, right? And after he's done making the masala, what happens? The kitchen staff comes in, they clean the kitchen, they wash the utensils, and they keep them back on the shelf. So this is how the tasks are divided in a kitchen between semi-skilled, skilled, and super skilled people to complete an operation efficiently. And this division of labor is what Narayana Health applied to their operation to divide the task between senior surgeon, junior doctors, and nurses and technicians. So while the American surgeons did a lot of pre-operation tasks, the operation and the post-operation tasks, here's what the Narayana Health doctors did. Look at this. Just like the head chef handles the most critical task of roasting the spices, the senior surgeon only handles the core surgical tasks of performing precise incisions like the bypass grafting or valve replacement. And most importantly, she ensures that the heart is functioning properly during the surgery. This is the most crucial step that determines the success of the surgery. So the senior surgeon might spend close to 30 to 45 minutes in the entire operation, focusing solely on the critical parts of the operation. Everything else is done by the junior team. So just as the sous chef grinds and portions the masala, the junior doctors assist with important preparatory and supportive tasks. So they prepare the grafts, position the patient, and set up the surgical site, and they assist with the sutures and equipment handling. So the junior surgeons ensure that the surgeon has everything they need to perform the operation efficiently and with 100% concentration. And here, the time spent by the junior doctors may be anywhere between 1 to 1.5 hours. And lastly, just like the kitchen staff in a restaurant, the nurses and technicians ensure that the tools are clean and they're in place for the surgery. So they prepare and sterilize the surgical instruments, they set up the monitors, and after the operation, they manage the post-operative care. And they spend a lot more time on the patient than the surgeon and the senior surgeon. And this time could be anywhere between 2 to 10 hours depending on the operation and the patient. This is how the division of labor in the heart operation process enabled the senior surgeons of Narayana Health to only focus on the core task, and everything else was taken care of by the junior surgeon, nurses, and technicians. Whereas if you look at American hospitals, back in 2011, the American senior surgeons used to oversee and do a lot more tasks in the operation, which could be done by junior surgeons and nurses. So while the American surgeons did tasks such as pre-operative preparation, patient education, charting, and even more routine surgical tasks, a Narayana Health surgeon only performed the actual critical surgical procedures. And this gave Narayana Health 3 incredible superpowers as compared to the American hospitals. Number one, the overall cost per surgery dropped significantly because the most expensive resource, which is the senior surgeon, he is used only for the most critical tasks. Number two, and because a traditional surgeon in the US handled both critical and non-critical tasks, they stayed limited to just 1 or 2 surgeries per day. But at Narayana Health, surgeons were able to perform 3 to 4 surgeries per day. So this model doubled or sometimes tripled the productivity of senior surgeons, allowing Narayana Health to cater to a much larger number of patients. And lastly, with faster turnaround times, the operating room is utilized more efficiently, which again reduced downtime and increased the number of surgeries performed daily. This is how Narayana Health reduced the cost of operations and reduced the stay of the patients in the hospital, which again reduced the cost of the stay per patient. And they did not just do this for the doctors, they even did it for the machines. In the US, big scanning machines like MRI and PET CT scanners are barely used for 3 to 5 scans a day. And this is the reason why scans were and still are expensive in the US. But Narayana Health does it very differently. Their machines work 24/7 non-stop. They even give patients discounts to come for scans at odd hours like late at night. And because of this, their scanners did up to 20 scans a day, which was way more than in the US. And guess what? This made each scan much cheaper, because of which more people could afford it. And eventually, the hospital did not need to buy extra machines. Similarly, they also practiced frugal innovation by reusing single-use devices. For example, in the American hospitals, many surgical devices such as the steel clamps for heart surgery are discarded after a single use. But at Narayana Health, these devices are sterilized and reused 50 to 80 times by following a strict sterilization protocol. So a 13,000 rupee clamp is reused multiple times, which reduces its effective cost to just 200 to 300 rupees per use. This again ensured cost saving without compromising on patient safety. But there is one question that still remains unanswered. How on earth did Narayana Health conduct free heart surgeries and still make a profit of 400 crores? Well, here's where there is one amazing model that Narayana Health has built, and this model is called the cross-subsidy model. So under this model, higher income patients pay more and the poor patients pay less. So while a wealthier patient pays about 2.5 to 3 lakh rupees for a surgery, a low-income patient might pay 50,000 rupees, and if they cannot afford it, Narayana uses its profits and donations to make these surgeries free for these people. And look at this. Each year, more than half of the patients received free or subsidized inpatient care with an average discount of 15%. This is how, ladies and gentlemen, Dr. Shetty revolutionized heart surgeries in India to such an extent that he was able to provide free heart surgeries to thousands of people all across the country. So this is how, using efficiency and profits, Narayana Health has revolutionized the process of heart surgeries, which is now being studied all across the world, including the Harvard Business School. And this remarkable story has 3 very, very important business lessons for all of us. Lesson number 1, true innovation doesn't require unlimited resources. It emerges from the need to solve pressing problems with what is available. In this case, by applying concepts like the assembly line model and frugal innovation, Narayana Health delivered world-class heart surgeries at a fraction of the global cost. Lesson number 2. Dr. Velumani once said at our podcast that if your profits come from the customer's pocket, you can sustain. But if your profits come from your operational efficiency, you can scale to millions. In this case, Narayana's profit did not primarily come from high heart surgery fees. Instead, they stemmed from running a highly efficient system that can serve more people at a lower cost, which enabled scalability. And the last lesson that we all have to learn from this story is that compassion without strategy is naive. Business without a purpose is hollow. But when business is driven by compassion, it has the power to transform the world. In this case, Dr. Devi Shetty's compassion and business has given India a gift that we must remember and celebrate forever, which is why we made this episode as a tribute to Dr. Devi Shetty. So if you love this episode, please tag Dr. Devi Shetty and Narayana Health on Twitter and share it with as many people as possible. And don't forget to check out Ditto for an honest and spam-free experience. And use the link in the description to book a free call with
So this was Narayana. Moving on, I will take you to the website of Arvind. I want you to go through there as well. They're celebrating their golden jubilee a few days back. Watch this for Arvindam.
Worldwide, 285 million people are blind or visually impaired. 80% of that blindness is avoidable. A simple operation can restore sight. But for many, the cost of treatment is simply too high. Here in South India, in a city called Madurai, Aravind has been working to turn those economics around. When people walk into an Aravind Eye Hospital, they have a choice, whether to pay for treatment or to receive it for free.
The vision and the mission of Aravind is to eliminate needless blindness. Anybody can walk in, whether he's a rich or a poor, educated or uneducated, anybody will be treated in the same way with dignity.
No one is turned away, and patients do not have to wait for treatment.
Aravind does not work on an appointment system. Whoever comes across gets seen on that day. We never make a patient wait or come again for things that can be done on the same day.
Collectively, Aravind's network of hospitals see over 12,000 patients and perform 1,500 operations each day. The quality of treatment is the same for both paying and free patients. In this model, revenue from each paying patient supports treatment for 2 free surgeries. Aravind does not depend on donations or government support. Patient income funds all its growth and expansion. Their mission is to make the highest quality eye care available to anyone who needs it, rich or poor. Today, a streamlined workflow, rigorous systems, and a mindset of frugality enable Aravind to perform over 200,000 free surgeries each year.
It should be affordable to everyone. Everyone who has eyes must have a sight.
When Aravind first opened its doors and offered free service, it discovered another barrier to access. Many patients lived in rural settings, far away from a hospital. They could not afford the cost of the journey. Since these patients could not come to Aravind, Aravind went to them. A series of eye camps were launched in rural areas.
The camp is basically an outreach program. So we come to the places which are not easily accessible. We do a screening for them. And the patients that require surgery, we'll take them back to the base hospital, do a surgery free of cost, and bring them back here.
This woman has a cataract in her left eye.
கீழே பாருங்கம்மா நம்ம புற ரொம்ப இருக்கு சரியா அதனால பின்னாடி நரம்பு எப்படி இருக்குன்னு இப்ப சொல்ல முடியாது
காவட்ட போனாரு காய் கஷ்டப்பட்டு போனாரு அது நடுவுல வேலை செஞ்சா தானே வாங்குவாங்க ஒரு காட்டுக்கே போனாரு பில்லு போட்டு விட்டுருவோம் அது அப்புறம் கொஞ்சம் மங்களம் தெரியுதுங்களா இருட்டா கொஞ்சம் தடுமாறிக்கிட்டு விழுந்துட்டு என்ன பண்றதுன்னு வீட்டுக்கு வந்தாரு
சரியா அப்ப அந்த கண்ணு பண்ண மாதிரி எல்லாம் இந்த கண்ணிப்பு அந்த கண்ணிப்பு கொஞ்சம் தான் இருந்தது இந்த கண்ணிப்பு ஜாஸ்தி இருக்கு
She is one of 200 people from this village whom Aravind will bus back to the main hospital for surgery, where they will receive food, lodging, treatment, return transport, and follow-up care completely free of charge.
காசு வேணுங்கிற கதையை கட்டி பண்றது அதனால இலவசமா பண்ணும்போது அது வழியாக
Today, Aravind sees over 3 million people every year, but it started from very humble beginnings. The driving force behind it was Dr. Govindappa Venkataswamy, an ophthalmologist fueled by a compassionate vision.
He set out to cure blindness, not just in his own town or the state of Tamil Nadu, but for the entire world.
Here was a man who was able to look beyond the national boundaries, the religious boundaries, and look at every person and said, why should anyone be blind in this world?
In his early 30s, Dr. V, as he was known, contracted rheumatoid arthritis, a lifelong condition that left his fingers permanently crippled.
That experience gave him a feeling of a patient. Fear, depression, anxiety, pain, looking for somebody with a smile, longing for somebody with a smile. All those things he experienced.
Despite this illness, Dr. V trained as an eye surgeon and went on to personally perform over 100,000 operations. At the age of 58, Dr. V retired as a government ophthalmologist. With his brothers and sisters, he opened an 11-bed eye clinic called Aravind to continue his work. They followed 3 simple principles. We won't turn anyone away. We won't compromise on quality. We must be self-reliant.
Dr. B had this phenomenal vision. He was able to think 20, 30, 40 years in advance when he had a 11-bedded clinic.
India is a country of over 1 billion people with less than 20,000 ophthalmologists. Dr. V knew the scale of the problem demanded a solution of appropriate magnitude. It called for the development of highly efficient systems. 40 years later, his 11-bed eye clinic is now the largest provider of eye care in the world.
எந்த கண்ணு ஆபரேஷன் சரி
Optimization of workflow, particularly in the operating theater, has revolutionized the number of surgeries performed.
One of the ways which continues to work very well is for each surgeon to have 2 surgical tables. The surgeon sits in the center and is able to operate upon one patient, whereas the second patient gets prepared by a support team.
When one cataract surgery is complete, the surgeon just moves across to the next cataract table. The time between surgeries is greatly reduced, and the surgeon goes from performing 1 surgery per hour to about 7 or 8 per hour.
This way, a typical surgeon at Aravind is able to perform between 1,500 and 2,000 operations a year, against a national average of 400. In 2015, Aravind treated close to 4 million patients and performed over 400,000 operations at a fraction of what it would cost in other countries. And yet, their clinical outcomes meet or exceed those of hospitals in the West.
Good girl.
That number keeps the organization financially sustainable, keeps the individual productive, and we're able to reach more in the community and provide sight.
With her operation complete, this woman will rest in the hospital for a few days.
உட்கார்ந்து படுத்துக்கோங்க பாட்டிமா சரிங்களா ரெஸ்ட் எடுங்க
மருந்துலாம் ஊத்துறாங்களா
Today, a standard cataract operation involves removing the clouded lens and inserting a synthetic intraocular lens, or IOL. But in the late 1980s, there were no IOL manufacturers in India. Lenses had to be imported from the West.
Dr. Ravi said, I feel guilty that I am providing intraocular lens to the paying patient and I am not providing intraocular lens to the free patient. Just because the cost of imported intraocular lens costs $200. We should make intraocular lens for $10 so that we can give intraocular lens to everybody.
With no prior manufacturing experience, Aravind set itself the challenge of producing high-quality, affordable IOLs. In 1992, they opened a manufacturing facility that produced state-of-the-art IOLs and made them available for $10 a piece. Initially set up to produce intraocular lenses, Aurolab now also manufactures a wide range of high-quality ophthalmic pharmaceuticals, sutures, instruments, and equipment.
And as we know that Aerolabs, they are exported to 130 countries around the globe.
A lot of drugs which were of no commercial interest to big pharma companies because there wasn't a big enough market, especially in the West. We got into them because there was a huge need in India and other developing countries.
Today, Aurolab is a self-sustaining, vigorously profitable enterprise. It produces over 200 products, including 2 million lenses a year, that are exported to over 130 countries around the world.
Dr. V, along with the founding team, have ingrained this thought that if somebody is blind in the world, it's the problem of this organization.
A global mission requires extensive collaboration. It primed Aravind to see allies in its competition. Today, the Lions Aravind Institute for Community Ophthalmology shares Aravind's best practices with hundreds of eye care providers all over India and in 50 other countries.
I feel like I'm part of Aravind. Aravind means a group of people fighting against needless blindness.
We give away completely whatever we do, from software to formats to patient flow, the processes, and our financials, whatever specifics they need, we quite willingly share, because this is for a public good and for a public work.
One recent example comes from Mexico.
Sala Uno is a social enterprise, and we are replicating the model of Aravind in Mexico City. The founders of Sala Uno, they contacted Aravind, came here, studied the model, and started to create the business model in Mexico. So far, we have provided 12,000 cataract surgeries, and Aravind is just telling us what they have done well. They share the numbers, they share their strategies, and I feel that's the right way to do. Because when it comes to healthcare, it's a right. It's a human right.
There are three things which Aravind has been able to combine, which are very difficult and very rare to find together. One is the highest quality and excellence. One is the large number and the scale. And the third is the cost effectiveness. I believe that Aravind has been able to do this because of the spiritual foundation on which Dr. V created the entire Aravind initiative. This cannot be done purely at the level of the planning or having a high management degree or a great skill. It is, as I said, a thing of consciousness.
அவங்க நல்லா பார்த்தாங்க சரி நல்ல முறையாக நம்மளே நல்லா பார்த்து நல்ல முறையாக சொன்னாலா போட்டாட்டு புரியாத பாடுபட முடியல அப்படின்னு சந்தோஷம் தானே பாடுபட்டா சந்தோஷம்.
Dr. V's mission of eliminating needless blindness has not been completed. I'm not even sure whether it will ever be completed. It's the journey, it's the constant aspiration to be able to reach every individual. And every act of yours, can you make it a little better? That thought process is what Dr. V has seeded in each one of us.
When you use this word Aravind in the community today, after 40 years of its starting, they correlate to somebody who has removed the darkness from us.
We know more about this and we'll move to other one, okay? There is one more video about Aravinda, which is like of the similar aim. So once you get about that, you'll get to know how that is going to happen, okay? So they'll talk about more and in the second video as well, okay? I'll share the, so this is the, share the screen again, the YouTube channel of Aravind, okay? This is there. So their mission is to eliminate needless blindness from the world. This is their introduction. I told you in the class that Harvard Business School also studies Dr. Devi Shetty's model. So I'll show you, this is the official YouTube channel of Harvard Business School, and I want you to see.
26 or 27 years ago, when I did the first heart surgery, I clearly remember the patient paid today's equivalent of $2,000 for a heart operation. 26 years later, they're paying $1,200. Nothing in this world in service. What was $2,000, 26 years later has come down to $1,200. It's only by economy of scale. Today, we are privileged. About 12% of the heart surgery done in India is done by us. So we have the companies which supply products, they look at us differently. And we have converted our hospital as an academic institution. Every hospital we build, we treat it like an academic institution to train young people. And more than anything else, we are very, very conscious of the quality. The cheapest way to produce something is to make it the best in first attempt.
Why is that?
Then you don't have to repair it again. If you fix the heart properly during the first time, you don't need to take back the patient for a re-exploration or give them massive quantity of blood.
So now we move on to the other one. So this is also the future of telemedicine. We have studied a lot about the telemedicine. So here is Dr. Devi Shetty talking to you about telemedicine. So how has this been like efficient enough for them? Okay. So telemedicine के बारे में हमने बात करी कि क्या होता है. यहाँ पर Dr. Devi Shetty is talking about telemedicine and how he has applied it in Telangana. Okay.
And I'm a heart surgeon by profession. My name is Dr. Devi Shetty, and I'm a heart surgeon by profession. Question about young people developing heart disease. We have a serious problem in our hand. When I used to practice in England, most of my patients were old, retired people. In India, most of the patients I treat are the young breadwinners of the family. It's not the young son bringing his old father for a heart operation in my practice. It is the old father bringing his young son for a heart operation. What is the reason for this virtual epidemic of heart disease? The reason is we are genetically more vulnerable. We are 3 times more vulnerable than Caucasians in developing heart disease. And we have a very high incidence of diabetes. We are becoming the diabetic capital of the world. And diabetes leads to premature heart attack. And we have a very high incidence of tobacco abuse and smoking. There is hardly any perceptible campaign against adverse effects of tobacco, smoking, and in any other form. And our diet, Indian diet, is a recipe for disaster. We need to change our dietary habits in terms of going away from very oil-rich fried stuff into something which is subtle and something which is more rich with proteins and other stuff rather than oil. And Indians have virtually no intention to exercise. We are not very conscious about the benefits of exercise and the greatest virtues of exercise. So we need to change our habits. How many people walk in the morning or exercise?
How many playgrounds you see across the country? There are hardly any. So essentially, we have a serious problem in hand. We have to address it. First is the lifestyle. It's very, very important that we take heart-healthy food, reduce the oil content in the diet, reduce fatty food, fried stuff, ghee, butter, cheese, milk and milk products. You can eat fish and chicken, very little of red meat, very little of egg, preferably the white. Then smoking, tobacco. Smoking totally destroys the heart, so is the tobacco. So you have to stop the consumption of tobacco in any form. Then exercise. You have to exercise, keep yourself fit. If you're a diabetic, control your blood sugar. Most young people don't bother about controlling the blood sugar because they don't have any symptoms. Uncontrolled diabetes can damage virtually every organ. It's a silent killer. So control the diabetes. If the blood pressure is high, control the blood pressure. Then more than anything else, you have to change your perception towards life. It's very hard to create a perfect world. We have to accept it. We have to accept this world as it is than as it should be. That is the best way to accept the rules and regulations and the prevailing situation and buy peace within yourself. And my last advice for all of you is become spiritual. I'm not saying you should become religious. You should become spiritual. Believe in the existence of God who is going to take care of all of us. And the belief that somebody is there on top, taking care of all of us and everything what we do, can be a very soothing part of your life. First of all, we have to accept the fact that Indians are genetically 3 times more vulnerable for heart attack than Caucasians. Being an Indian is a risk factor. Then we have to see how we can reduce the chances of developing heart attack. For that, we need to change our diet. We have to reduce the oil content, fried stuff. We have to preferably become vegetarian fruit eaters. That is not possible, but lean meat is okay. Fish and chicken is okay. Then we should develop the habit of exercising. Somehow it is not in our culture to exercise. The third and the most important thing is if you are a smoker.
I hope you understand this. What is happening in this video is telemedicine, okay? So there are questions that are being asked and he is suggesting answers to those, okay? So this is one of the concepts of telemedicine. That is how it works, okay? That from one person, all the questions have been collected and he is answering those. And ek baar mein he is teaching various people, okay? So we'll see the other video, okay? So this is about understanding the health systems, okay, of the world.
In this video, we will discuss health systems. Specifically, we will focus on understanding health system definitions, frameworks, and debates. How is the health system defined? A system is an arrangement of parts and their interactions that come together for a purpose. Is it a health system or a healthcare system? Is it about activities or people and institutions who carry out these activities? For example, there are individuals and institutions in disease prevention and treatment provision. There are financial intermediaries, input producers, planners, administrators, regulators, and other actors producing system outcomes. The World Health Organization defined in 2000 that a health system consists of all organizations, people, and actions whose primary intent is to promote, restore, or maintain health. Like any other system, it's a set of interconnected parts that must function together to be effective. There are three key points here. First, it's about the diverse components in the system. Second, it's about the arrangement of parts and interconnections among the parts. Each component has interacting roles and functions. This is why system thinking is critical. If you look at one component in isolation, you will miss the many ways the component interacts with the other components. Third, all the activities in the system have a primary purpose to maintain health. There are several important characteristics of health systems. First, complexity. There are many actors, many products, and complex connections. Strengthening a health system involves large-scale efforts and takes a long time. And every institution involved must be committed to a long-term goal. Second, conflict. Though the overarching goal is to improve health for the population, different participants in the system have different objectives and interests. Third, politics matter. Current conditions reflect power in society, and a change incurs political process. Fourth, health system is embedded in social context. The culture, history, economy, and social norms are influential on health systems. How would you define health systems? My simple answer is that a health system is a means to an end. Keeping the end in mind is very helpful in evaluating health systems and thinking about health system reforms. Now, let's discuss two examples of frameworks for thinking about health systems. One is the Health System Building Blocks Framework developed by WHO, and another is the Control Knob Framework developed by a team at Harvard University. When you strengthen a health system, you improve the 6 health system building blocks and manage their interactions in ways that achieve more equitable and sustained improvement across health services and health outcomes. Here is a basic checklist of 6 key components for what to think about when we analyze the building blocks and plan to strengthen them in a country. Service delivery. Good service delivery comprises quality, access, safety, and coverage. Health workforce. A well-performing workforce consists of human resources management, skills, and policies. Health information system. A well-performing system ensures the production, analysis, dissemination, and use of timely and reliable information. Medical product.
So we have seen service delivery, health workforce, human resource skill from your MBA point of view, and then information as well as the products जो उसके इसमें use होंगे, ठीक है? So this just gives you more clarity about the more explanation about this. Okay, so we'll go to the next
products,
one.
vaccines, and technologies. Procurement and supply programs need to ensure equitable access, assured quality, and cost-effective use. Financing. A good health financing system raises equitable funds for health, protects people from financial catastrophe, allocates resources, purchases goods and services in ways that improve quality, equity, and efficiency. Leadership and governance. Effective leadership and governance ensures the existence of strategic policy frameworks, effective oversight and coalition building, provision of appropriate incentives, and attention to system design and accountability. After introducing the static typology of health systems, I would like to introduce a flowchart for comparison. This is the control knob framework. There are 5 control knobs or health system reform options as the means that can be adjusted.
Okay. So you understand what a system, the 6 things that she's talking about, okay? So you know what a system is and how that has to be applied, okay? That is clear. So जब हम हेल्थ केयर की बात करते थे तो हमने बात करी थी हमारा जो लास्ट यूनिट है हेल्थ केयर फ्रॉम अराउंड द वर्ल्ड, ओके? का हमारा बेस्ट सिस्टम कौन सा है? So this is a video where all the experts in the world are sitting and they are trying to find which country has the best healthcare in the world. So here you will get to know what is important, what is not, and इनको कितना struggle हो रहा है, कितने सारे elements हैं in that. Okay.
I want to start with a simple question. Which country in the world has the best healthcare system?
Yeah, so I hate that question. Here's where you should ask me why I hate that question.
I knew you were going to start with that question.
I think it's a question that a lot of people ask. Which country has the best healthcare system? And I don't think there's a correct answer to it.
It depends on what it is that we value.
I'll give you an answer, but then I'll tell you why the answer might not be applicable. If you look at the World Health Rankings, the country that came out on top is France. I think in general, starting from France and working northern, you tend to get the best healthcare systems. But the reason why it's not entirely applicable is that what works in one country may not work in another country.
So a number of years ago, just a few years ago, I wrote a piece in the New York Times with my colleague Aaron Carroll. We actually did a tournament of health systems. It was like a bracket tournament, the way March Madness is a bracket tournament, or like a tennis tournament. And we had me and Aaron, Uwe Reinhardt, Ashish Jha, physician, now Dean of Brown, and Craig Garthwaite, an economist at Northwestern. And we each voted in each of the brackets, like in each of the pairings, for which system we liked better. And then we ultimately got a winner. But one of the important takeaways from that whole process is that
If you're understanding the process of it, कि इन्होंने कैसे करने की कोशिश की है, still इनको कुछ मिलेगा कि how difficult it is for them to go through.
in no pairing did any country win 5-0. There were 5 of us, right? We were not unanimous in any decision. There was always at least someone who disagreed, and in many cases it was 3-2. And we each had different reasons. You know, someone was very big on like the cost, equity, access, or the quality. And so to me, like, look, this is 5 people who know healthcare pretty well and know these systems pretty well, and we couldn't even agree. So there's just no clear winner, actually.
But the one thing that stands out is that among all major developed nations, it's pretty clear that the United States comes in dead last.
On the other hand, I think everyone, especially experts, should be skeptical that they know the answer, because what works in one country or one setting doesn't necessarily work in another.
So, you know, there are aspects of the Australian system I like. There are aspects of the English system I like. But I don't think that there's a system we could just bring over here and install like a new fridge.
So maybe the better question is, what would the best system for the US look like?
And what would that look like?
So a good healthcare system, or let's just call it a healthcare system. A good healthcare system has, I think, to me, several attributes. One is,
how does it affect our health as a country?
How long is it that people are living? What is the infant mortality rate? What is the rate of certain types of diseases, and how well are they doing in prevention?
And the second question I'd want to know the answer to is, were the benefits of the treatment greater than the cost of the treatment?
A bad healthcare system could have overspending on care that's of really questionable health benefit, at the same time that it has underspending on healthcare that's of vital importance to people. So when people say, do we spend too much on healthcare? We spend way too much on some things and way too little on others. So a good system would fix both problems.
And the third dimension for healthcare system is, how well does it reflect our values as a society?
And by values, I mean, what are the rich willing to do for the poor? What are the healthy willing to do for the sick? The answer to that doesn't come from economics. It's an answer that we all have within us. But that answer profoundly affects how you answer questions about what's good and bad about healthcare.
And I would hope that going forward, as we think about the learnings from other countries, we can take a hard look at what it is that we have and whether they align with our core principles that we otherwise hold so dear.
So my goal is have a health system that does the most it can to improve our health, that protects people from financial ruin, and that conforms to our values as a society.
So yeah, that would be the right thing to do in principle. The next question should be like, can we get there from here? And I just don't see it.
What we've seen over time is that costs of healthcare have gone up, but outcomes have also improved. So if we take some measure, and the measure that I like to use is life expectancy at age 40, and then I look on the other axis at the cost of healthcare per person. And what you find is, if you look back to 1976,
all of these countries, the US, Germany, Canada, look similar in terms of what share of GDP goes to healthcare.
and they are all living, people are living about 35 years after age 40. Okay.
Fast forward 20 years, and the US is spending a lot more of its GDP on healthcare, and its life expectancy increases have not kept up with the life expectancy increases in other countries.
So the US becomes increasingly an outlier, both in terms of outcomes, that is life expectancy, and in terms of spending.
Now, you can put the two on the same graph, but that doesn't mean that they're related in any way. I think we're simplifying the other healthcare system to the point of getting it totally wrong. But a lot of it depends on who you're talking to, right? I think there's a view that some Americans have that in other systems care is terrible. You know, there's very long waiting lines and waiting lists, that the latest medical technologies are routinely not available. I think for a lot of other Americans, there's this view that other countries have just figured it out. And what we should be doing in the United States is copying what they've already figured out. And I think both those views are not right at all.
So I think people mix up this term called socialized medicine with what I would call universal health care.
One is the insurance part. That is who runs the insurance. And you can have socialized insurance where the government is running the insurance, or private insurance or private companies, or both. And then second, there's the providers of medical care, who could be either government-run employees or private employees.
There are some methods that one could classify as being socialized medicine, meaning that the government is a single payer, the government operates all the healthcare, and people belong to a single government system.
So Britain has socialized medicine because the hospitals are government institutions and the physicians and nurses are government employees.
And France has yet a different kind of a system, also not government owned. And Switzerland, Netherlands, Germany, these are places that have universal health insurance, but they have active and important private health insurance companies that administer it. So very different structures of these systems. The thing that they share in common is that they're universal.
So I think, coming full circle, my great worry with healthcare reform in America is that it has collapsed to the level of kind of fighting and arguing about these slogans. And the slogans have nothing real behind them.
These slogans have become so politically charged and tied to a particular candidate or a particular viewpoint that has become completely partisan and will shut down constructive debate.
And if you go back to what I was talking about, how do you evaluate a good healthcare system? You don't evaluate it by the share of government in the system. You evaluate it by whether patients want the care that they get and whether the care that patients get is worth it. I think that other countries have great hospitals, cover a lot of medical treatments, have fantastic doctors, and at the same time, they have not figured out a bunch of things that we have not figured out. So if you are the kind of person who's going without health insurance in the United States,
I hate to say it, but I think they are better off in many other countries than here in the US.
But for a lot of diseases, for a lot of
This is exactly what we discussed. If you don't have health insurance in US, it's very difficult to sustain because a minor medical procedure can cost a lot. उस basis पे thing, but any rare disease, R&D, वो वहाँ का बहुत ज़्यादा strong है. So they'll end this video and there's this another infographic that you'll see, which is focusing on the US healthcare market. Okay. So let me start.
people, regardless of income, this is probably the country where you would like to get your healthcare.
My wife stopped trusting me because I never do the things I say I'll do. She just does everything herself now. If you look at lists regarding which countries have the best healthcare system, you'll likely see Sweden, Denmark, Canada, Germany, Switzerland, Japan, the Netherlands, and Singapore somewhere on the lists. But how do they compile such lists? Well, taken into account is how much countries spend on healthcare, the quality of that healthcare, the availability of it, and of course, how effective it is in keeping the country's populace healthy. Another thing on the list is how much people might have to pay up front for the healthcare, if anything at all. This is one of the reasons you won't find the USA on these lists. With the American media often telling us being sick in the US can bankrupt a family, today we'll find out how this happens in this episode of the Infographics Show, US Healthcare System Explained. Before we begin to explain the system, we might ask if medical bills do actually cause so many problems in the USA. According to CNBC, that is indeed a fact, with one report saying medical bills are the leading cause of bankruptcy in the country. How many bankruptcies? No one knows exactly. You'll find some statistics saying that around 650,000 Americans every year go bankrupt because of medical bills. President Obama said there was a medical bill-related bankruptcy in the US every 30 seconds, but that was way back in 2009. These numbers have been contested, and skeptics tell us there is always more to bankruptcy in these cases than just medical bills. Maybe those bills were just the straw that broke the camel's back. But one thing we can take from the stats, even if not entirely accurate, is that America, a country so developed and rich, might not be doing a good enough job looking after its citizens. The website The Balance wrote a very balanced article on this topic. It came to the conclusion that one must save in America, as sickness or accidents can lead to astronomical bills. The advice it gives? Save for a rainy day in a hospital bed, and live a life in line with not getting an ailment often unavoidable, such as diabetes. Shouldn't the developed nation have safety nets in place, though? That's a question many Americans ask. How many Danes go bankrupt because they were unfortunate enough to be hit by a bus? We might recall the recent video that went viral of a woman who had her leg trapped by a subway train in Boston. "Don't call an ambulance," she cried, as shocked bystanders witnessed her bone coming through her leg. "Why?" they asked. She replied, "Do you know how much an ambulance costs?" So what's going on? The Department for Professional Employees tells us this: the American healthcare system is unique, at least for an advanced nation. That's mainly because the USA is the only industrialized nation without universal healthcare coverage. That doesn't mean it doesn't spend a lot on healthcare. In fact, it spends a lot, a hell of a lot. About 17.9% of the GDP in 2016, or $3.3 trillion. We're told that Americans shop for health insurance just as they shop for anything else. Around 156 million Americans are insured through their work, which is called employer-provided private insurance. Then you have publicly funded Medicare for old folks and the disabled, and Medicaid for the poor. It's thought around 120 million Americans are part of these schemes. That's why the system has been called a public-private hybrid. But when we talk about insurance given or subsidized by employers, it all depends on what kind of insurance you have. It may not pay for everything, so some people still end up going bankrupt. Then you have the Affordable Health Care Act, or ACA, aka Obamacare, which attempted to make it easier for employers to give better health insurance plans for their workers. It also made it possible to give the maximum time limit for short-term insurance plans, and make it possible for employers to give their workers pre-tax cash to buy their own coverage. As we said though, insurance providers don't always give you exactly what you want. They usually have a network of doctors or hospitals, and you must use them. And in some cases, you are not always covered for the treatment you need. In the past, some people with pre-existing conditions couldn't afford their insurance, or were even denied it, which is just a part of cutthroat capitalism. Obamacare was put in place to prevent this. But let's go back to insurance. When you choose a plan, you must look at these things: deductibles, co-payments, co-insurance, and premiums. The package you buy, according to these things, might save or break you. Premiums are what you pay even if you don't make a claim. These can be very high. Co-insurance is a percentage of the cost you pay. A deductible is what you pay before insurance pays for anything, which can be as much as $10,000. A co-payment is what you must pay for every visit to the hospital or clinic, and you'll pay that before the insurance company pays anything. So choosing the right plan is important. As one writer puts it, you've got to be an odds maker on your own health. So what if you have no insurance? As we said, there are government-funded schemes for those in need. Also, because of the Emergency Medical Treatment and Active Labor Act of 1986, hospitals can't just turn you away if you're at the doctor with blood spurting from your neck. There's also the Hippocratic Oath, which means all doctors must try to treat you the best they can and do it ethically. But if you can't pay, there will be a bill. And in the US, it will likely be a large bill. That could lead to debt collectors coming for you, your wages being garnished, part of the money taken out, your credit being ruined, having a tax refund withheld, someone wanting to take your house, or you could suffer bankruptcy. But surely those with decent insurance won't hit rock bottom. Not according to the Kaiser Family Foundation. That tells us more than 25% of US adults with insurance have difficulty paying their medical bills. You see, we're told that 63% of Americans who have had these medical bill woes had to spend most or all of their savings on those bills. Another 42% had to get a second job. CNBC wrote in 2018, only 39% of Americans have enough savings to cover a $1,000 emergency. Experts tell us Americans should downgrade their lifestyle in case they get sick, even if they have insurance, as going bankrupt could mean you might not get a loan again, or be able to rent a house, or even get a job. Sure, the poor and needy might get government help, but those that fall somewhere in the not poor but far from being comfortable category are often those who have to risk average insurance and the possibility of getting sick ruining your life. Another thing we're told is that 1 in 10 Americans delay getting treated because they're worried about the cost. That's what you might call a vicious cycle, because waiting can just make things worse. Some folks can't even afford the deductible, even when it's just $500. The bills themselves may often surprise those that got treated. According to a story in The Atlantic in 2014, one man had a herniated disc surgery in America. He made sure he had enough cash for the surgery. As the article said, $56,000 in hospital charge, the $4,300 anesthesiologist bill, and the $133,000 fee for the orthopedist. But there was an extra $117,000 for an assistant surgeon that it turned out. One would think at these prices you could walk out of the hospital not only fixed, but in a Hugo Boss suit with the keys to a new car and 2 tickets to the next World Cup final. But no, you get fixed and leave with only a big bill. This is mainly because of administrative costs, the sometimes ridiculous cost of drugs, the fact that you pay for the possibility of doctors being sued, paying healthcare workers wages, new technologies, and medical institutions just charging you what they want. We're told by Reader's Digest that some hospitals charge $8 for a mucus recovery system. They're usually called tissues. An investigation revealed one patient was charged $53 per pair of non-sterile rubber gloves. Sterile gloves were more. Total cost for the stay, just in gloves, was $5,141. That plastic cup they use to hand you your drugs, $10. With an average of $440 in cups for a patient's stay in the hospital. Alcohol swabs, of which you may need many, $23 a time. One person was charged $137 for an IV bag. The cost of that bag, $1. This is mostly due to something called the Charge Master, which allows hospitals to charge out-of-this-world prices. These codex of costs are hospital-specific, meaning each hospital makes up its own prices. Some critics have called such costs fiction and are critical of the lack of transparency hospitals provide about this hidden menu. The loser, of course, is the consumer, whose life may depend on that 5-star menu. Vox reports that one woman who hit her head and went to the ER left with only an ice pack and a bandage. Her bill, $5,751. Her insurance paid $862, and she had to pay $4,989. Okay, she paid for assistance and expert evaluation, but come on. In fact, most drugs or treatments will cost Americans much more than citizens of other countries. In fact, the Washington Post tells us America has the most expensive but least effective healthcare in the developed world. Now you might see why people in the US are going bankrupt, and why the country is not on any best healthcare lists. This is a huge debate in America, and today, we may have been quite critical of the healthcare system. We'd love to hear counter-arguments, or even your own experiences with the healthcare system. Let us know in the comments. Also, be sure to check out our other video, Most Horrific Crimes, the Italian Mafia. Thanks for watching, and as always, please don't forget to like, share, and
pick any
If you look at lists regarding which countries have the best healthcare system,
Everything that you heard about the American system is something that we have discussed in detail in the class, okay? So now when we move on, we have to make sure that we also look at the other systems of the world, okay? So Germany के बारे में हमने discuss करा था. It has बहुत पहले से it has the employer and employee scheme, okay, and how it was working. So now we will move on that, okay, and we'll see how that goes, okay. So I'll share the screen and you see about the Germany's healthcare, okay.
70% of Americans say the U.S. healthcare system is in a state of crisis or that it has major problems. That's why we're hearing a lot about Medicare for all, including some plans going as far as banning private health insurance companies altogether.
On page 8 of the bill, it says that we will no longer have private insurance as we know it. And that means that 149 million Americans will no longer be able to have their current insurance. That's in 4 years. I don't think that's a bold idea. I think it's a bad idea.
Problem, Senator Sanders, with that damn bill that you wrote, and that Senator Warren backs, is that it doesn't trust the American people. I trust you to choose what makes the most sense for you, not my way or the highway.
One country found a way to provide universal healthcare coverage while maintaining a competitive insurance market that offers citizens more choices. Germany. Here's how they did it. In 2017, US healthcare spending came to around $10,200 per capita. In Germany, it was a little under $6,000. Overall, Germany spent about 11.2% of its GDP on healthcare, while the US spent 17.1%. Germany manages to cover 100% of its population. In the United States, about 8.8% of the population remains uninsured. That comes to about 28 million people, with even more people underinsured. Despite spending less, Germany has better or comparable health outcomes to the United States. Studies show that in Germany, there were fewer deaths that could have been prevented with proper access to care. In 2013, there were 83 avoidable deaths out of every 100,000 people in Germany, while the United States had 112. Life expectancy in Germany is 2.5 years higher than the United States, and the infant mortality rate is lower in Germany, with 3.3 deaths per 1,000 live births.
Keep in mind that amount of money that US is spending percent of GDP is more than that of Germany. Okay, it is. हमने बात करी थी ना 17% of GDP, तो पैसे US ज़्यादा लगा रहा है हेल्थकेयर पे, ठीक है?
Births, as opposed to 5.8 deaths in the United States. Additionally, the maternal mortality rate in the United States is more than 2 times higher than in Germany. So how does Germany manage to have better health outcomes while spending nearly half as much as the United States?
Germany is a system that would look familiar to Americans in that everybody buys health insurance from a private company. And then the doctors and the hospitals and the labs are almost all private.
That's T.R. Reid, author of the book, The Healing of America. He traveled the world exploring different healthcare systems and how well they worked.
But it works better in Germany for a couple of reasons. One is everybody is covered. Everybody is required to have insurance. Everybody's in the system. The insurance companies can't turn you down because you had cancer last year or something. They have to take you. They have to cover you. Everybody has access to the same treatment, and all the doctors, you can go to any doctor without any limit set by the insurance company.
In Germany, health insurance is mandatory for all citizens and permanent residents. There are 2 different systems that residents can turn to for insurance: SHI, which stands for Statutory Health Insurance, and PHI, or Private Health Insurance. German citizens are eligible for PHI if they make more than roughly $60,000 per year, or if they are self-employed. Citizens making under that threshold must pay into SHI. SHI is made up of a network of competing not-for-profit private health insurance funds, known as sickness funds. In SHI, dependents are covered free of charge, and monthly costs are capped around €840 per month. Even though SHI sickness funds are not government agencies, many Germans think of them as part of a public system because of heavy regulation. Keith Tanner helps expats navigate the German healthcare system, and he considers SHI sickness funds quasi-public organizations.
Basically, they have to do what they're told. They are told by the government in what range they can charge. They're told what health procedures they can fund, and they are told by the government who they can accept as clients. So they're really just carrying out orders.
They're basically charities. They don't exist to make a profit for investors like American health insurance companies. They're there to keep people healthy. That's what they're there for. They follow all sorts of rules that American insurance companies wouldn't dream of.
The system is funded through compulsory contributions based on a percentage of citizens' salaries, with employers sharing the costs. There are also built-in safety nets. The government will pay into SHI on behalf of the long-term unemployed. Despite being non-profit organizations, sickness funds compete for customers by offering specific coverage and perks. This competition has changed over the years as the system has allowed citizens more choice. As of 2019, there are about 100 statutory health insurance companies, but there used to be many more. When Germany's system was first established in the late 1800s, sickness funds were linked to a person's profession. It used to be that people were assigned to a specific sickness fund based on their occupation or region. Now Germans can choose where they enroll, and they can change funds on a yearly basis. As a result, sickness funds began marketing themselves in order to retain customers and attract new ones. This also led to the funds merging, so they could become more competitive. Some of the sickness funds offer perks that might seem similar to credit card rewards.
You still can get a bonus for going to the gym, the bonus for having a checkup. This is in the public system. And if you get a certain number of bonus points, then you get a voucher. But kind of trivial stuff like 200 a year or something like that, 200 euros a year, nothing which is completely relevant to the person who's paying their 840 a month.
As of 2017, roughly 87% of Germans received their primary coverage through SHI and 11% of the population through PHI. The remaining population, such as soldiers, police officers, and refugees, receive health insurance through specific government programs. All individuals insured through PHI pay a risk-related premium with separate premiums for each dependent. These risk-based premiums mean that costs will increase as the insured gets older. As a result, the government regulates PHI so people don't become overburdened by premiums as they age.
The biggest issue with private health insurance, if you opt out of a public system, is affordability in old age. If you don't impose these financial constraints on the insurers, then the government will be lumbered with a whole lot of old people who reach 85, 90, 95, and are going to be totally unable to pay for their health insurance. So it'll all fall back on the government.
Once someone switches to PHI, they cannot switch back to SHI in the future. But Tanner says there are ways around that.
If you're a freelancer in the private system, you're just going to get a job, paying less. There's a threshold. Any employee earning under about 5,000 a month is required to have public. If they earn more than that, they can opt out. So if you are a freelancer, you want to go back into the public system for some reason, then you get a part-time job with a friend, pays you 500 a month for a few months, and then you're back in the public system. So there are ways to do it. The only reason you probably want to do that, though, is if you have lots of children, because children can be covered free in the public system, and the private system have to pay separately for each child.
Germans can also buy supplemental private insurance while staying in SHI. For example, many Germans buy supplemental dental insurance.
The public system pays like for major dental work about half the cost, and then we get supplementary to take it up to 80, 90% of the cost.
So I hope the German system is clear. क्या बात कर रहे हैं वो कि पब्लिक सिस्टम में प्राइवेट सेक्टर, तो तुम पब्लिक जब तुम प्राइवेट से भी इंश्योरेंस खरीद रहे हो ना, इट इज एक्सट्रीमली हेवीली रेगुलेटेड. ठीक है, हमने क्लास में डिस्कस किया है, रिवीजन में भी हमने डिस्कस करा है. This is we are trying to again look at through other perspective. Okay, so now हम एक सिंगापुर का एक और मॉडल देख लेते हैं. ठीक है, सिंगापुर is actually one of the best in the world. So इसमें सिंगापुर मॉडल में 3M की यूज होता है. The 3M is considered one of the best. So this will be like really not well. So we will close after this one. Okay, so all of you please pay attention.
Hospital in Singapore, they will literally have a menu. It looks like a restaurant menu of everything they do and the prices.
Before we get into the particulars how Singapore does it, the prices of a couple of procedures in Singapore versus the US. And it's important to understand, again, the quality is as good or better than the US. The doctors are paid as well as doctors in the US when you take after-tax income. Singapore has a very low income tax system. Technology is high tech. They don't skimp on the technology. So quality of physicians, technology, equipment, everything, you can't say they're skimping on an area. So, but give us the cost of a couple of procedures, what you'd pay, what you'd be charged for here and what you'd be charged for in Singapore.
Okay, so I found several, a dozen or so of these that I could do price comparisons on for the book. And the one that really stood out for me, and this is partly as my father before he passed away had a quintuple bypass surgery, was that the average amount that a bypass surgery in the United States costs, bills out for, is about $130,000. In Singapore, it's $18,000. And when you think about that, $18,000 is half the cost of a new car in America, right? New car in America, I think, hit $36,000 last year. Most people can buy a new car. Maybe they don't want the fanciest new car, but average people buy average cars. They can pay it off over 5 years. And so what Singapore has done in terms of financial security for individuals is they've taken what here would be a financial catastrophe. Who has $130,000 lying around? Very few people have that, or they'd have to clear out their 401k or something, even if they've got some money saved up, or sell their house. It's a financial catastrophe for most families. But $18,000, that's something that people could pay off $200, $300 a month over 4 or 5 years, something like that. And so they've transformed what is a catastrophe due to their efficiency into something that's really inexpensive and just another consumer good, which is actually a good thing in this case.
So let's walk through the particulars of the Singapore system, where the government plays a large role, but somehow we get free market economics, a lot of competition. So describe the system, starting with what, if you are a person in Singapore, you must make mandatory contributions like we do with the FICA here in this country, but the difference being you control that money. Walk us through that, how they make this system work, and where the consumer is in control. Even the government subsidizes that account.
Yes, so it's quite amazing. And the Singaporeans like to refer to the overall system as the 3 M's. And I'm going to talk, and M as in Michael, but the M's are MediSave, which is what you're referring to just now, which is their savings program for healthcare. There's MediShield, Shield being insurance. And then there's MediFund, which is a giant trust fund that makes sure that the indigent get equally good care to everyone else in Singapore. And so the first pillar is that MediSave. It's been in place since the early 1980s. And what it does is it requires people to save about 7% of their gross income into health savings accounts. The money is their personal property. If they die early or something happens, they can give it to their heirs and assigns. Once they reach retirement age, they can start transferring healthcare savings over into regular retirement savings where they can access it. And so everyone here knows that that's their own personal money, such that if they need a medical procedure done and it's their money and it's not third-party billing like it is here where someone else is paying the cost, they think to themselves, wow, I want to get this done right, but I want to get it done at the lowest cost. And then they go out into a healthcare marketplace, Steve, where price tags are mandatory. You go to a clinic or hospital in Singapore, they will literally have a menu. It looks like a restaurant menu of everything they do and the prices. And they give you bundled prices. Like here, if you get an open heart surgery, you get 800 billing codes. There, they'll just say, here's the bundled price for the whole thing. Take it or leave it. And people can do this. You can go online in Singapore and comparison shop. Like if you needed a knee surgery, you could find out what every hospital in the country is charging. And then the government, to make it even easier to be a good consumer, publishes things like mortality, morbidity, and complication rates by providers. So you could, for instance, say, oh, this doctor over here is less expensive, but 1% of his patients die, whereas this other doctor over here, it costs more, but no one dies. And then if you're like me, you'd probably go to the cheaper doctor thinking, 1 in 100, that's fine. And so the doctor who has sort of the lower quality and the lower price, he's under competitive pressure to raise his quality. And the doctor with the higher price and the higher quality, he's under competitive pressure to keep his quality up and lower the cost. And so in this way, there's competitive pressure for both price and quality of services.
And again, the outcomes there are better than they are here. And buying the insurance itself, do they buy it out of that first M? Or how does it work? You buy your own insurance. It belongs to you. So if you change jobs, it goes with you. It's your property, not the employer's property.
Yeah, I'm glad you brought that up, Steve, here, because due to changes in Obamacare, we've really restricted the use of health savings accounts here in America. And among other things, the money in them cannot be used to pay for premiums. And this is even true for people who are self-employed. Meanwhile, in Singapore, yes, people pay for their own health insurance premiums out of their own health savings accounts. So they're aware of the price of the insurance, which is great. And then they're also aware that under Singapore's system, and this is sort of the second stage, the MediShield part, the insurance part, it's high deductible insurance. So the first $2,000 a year of spending are on them. And so this puts sort of, you could call it sand in the gears, or you could call it just a little bit of friction, but it makes people pay attention in a way we don't have here.
Also, the insurance is age related. So if you're a 20-year-old, you can get it for a few dollars a year. If you're 80 years old, it's going to be higher. But even so, with the competition where you're writing the check, the insurance premiums are a fraction of what we pay here.
इस बूमिंग क्रिएटर इकोनॉमी में एक हाई पेइंग करियर बनाना चाहते हो एक क्रिएटर के लिए जो सब
Yes, well, it's startling. So, you know, I'm 47 now. The health insurance policy my company is paying for is $20,000 a year, Scripps College. In Singapore, I could get this actually better quality insurance, right? Because you don't have to worry about in-network and out-network and all sorts of things. My insurance bill a year would be less than $1,000, which is another reason why these health savings accounts work so well, is that the costs of buying insurance and even the annual deductibles are for most people, unless something really catastrophic goes wrong, much less than the amount of money in their health savings account. And the government of Singapore actually guarantees the money 4% returns. So it's accumulating. Most people are quite healthy till they're about my age, right? So from, you know, getting out of high school or college, they'll work 20 years, just pile up savings. They're very healthy. And then what's really wonderful about this, and, you know, I had a father who was born in 1925. And so I've had to deal personally with the decline of a relative from robust health into, you know, eventually death and senescence. But that is hideously expensive. You know, most healthcare costs are in the last few years of life. And the only country in the world that has money saved up to pay for the graying of the population and people getting older is Singapore with these health savings accounts. Whereas by contrast, Medicare currently has, I think, a $39 trillion hole in its trust fund over a 75-year planning horizon. And so we and Europe and Japan, even Korea, that we're going to have to, unless we do some real reforms here, we're going to have to unplug Granny in 20 years, right? We're not going to be able, they're just going to start making really awful decisions.
Now, in Singapore, these savings, I'm not sure which of the M's they're parked in, or maybe they change over a lifetime, but they've saved up equivalent, I think you've said 5 years of healthcare costs. Now, healthcare is $3.6 trillion in the US. So if we had 5 years worth of healthcare costs saved up, would be 18 trillion, a number that is so astronomical, it's not believable. But in Singapore, 5 years have been saved up over the years.
Yes,
5 years.
And the money is still accreting, it's still growing. But yes, so we, and you know, an interesting comparison in the book is that I, as you pointed out, Singapore, there's so much money in these health savings accounts, they could run all healthcare spending in the country for over 5 years. That's all spending, public, private, everything could be paid for 5 full years with just the money in these health savings accounts. By contrast, there is so little money in health savings accounts in the United States that I ran the numbers, and for the most recent year, there was only enough money to pay for 13 days worth of healthcare services in the United States. So it's not even close. And so that's another way of saying they're so much better protected. They're hundreds of times better protected financially than Americans are.
Now, can you change your plan? I buy a plan from company X at 22. When I year? Can I decide I don't like that? Can I change it? Is it easy to change plans?
Yes, you can. And so the way the government's been doing this is the government in Singapore sets what's covered and gives not exact, but pretty restrictive rules to these insurance companies, or people are going to bid on them, as to what the insurance will cover and how much premium should be in this and that. And then they put it up to collective, not collective bargaining, what do we call it? It's sort of an auction process. And insurance companies actually bid on the right to be one of 5 companies that can actually offer these policies. And they have to compete with each other. They have to compete to even be in the game. And then
how often must they compete to stay in the game?
I believe the auctions are held for the companies to get the rights every 3 years.
So if you win once, you've still got to perform, or you're not going to get it again.
That's right. And people can also, in the meantime, do something that I think is crucial in free markets, which is vote with their feet, right? Take their money, go to a different insurance company and get a better deal. And so that's wonderful here. And people in Singapore aren't locked in to their health insurance for an entire calendar year, right? Here in November, at most companies, you have a benefits fair and you sign up for healthcare that starts January 1 of the next year. And basically, if you change jobs or anything or lose your job in that time, you're in big trouble, because even if you have the money, it's cumbersome, even with, you know, the things that Obamacare tried to do with these gold and silver and bronze plans, to go out and buy yourself new health insurance coverage. And so we have COBRA laws and all these other things to try and put a bandage on that problem. But as you point out, there's no problem in Singapore, where insurance is cheap, affordable, and there's options, and you could change it anytime.
I hope that is clear to you. What is that is Singapore is doing right. Okay, so now हमने सिंगापुर की बात कर ली है. Now एक developing country का example देखते हैं, and then we will wind up our class today. Okay, and hopefully I'll be better in the next one. तो हम अपने एक system की बात करते हैं, ठीक है, which एक which is really interesting, and हमने class में भी discuss करा है इसमें, which is about the ASHA workers. Okay, so what we are doing here, and who are ASHA workers, and how is that going? Yeah.
Chapter that to understand ASHA and USHA, we must first look at the National Health Mission context. To understand
lakh ASHA workers across the country. Accredited social health activist workers, or
Sorry, I'm not sharing my screen. Okay. So this is who are ASHA workers.
accredited social health activist workers, or ASHA workers, are India's frontline rural healthcare workers. They are female community health workers trained to function as a bridge between the community and the public health system. They have recently won the WHO's 2022 Global Leaders Award. The honor recognizes contributions to advancing global health, leadership, and commitment to regional health issues. Prime Minister Narendra Modi applauded ASHA workers for ensuring a healthy India. ASHA means hope in Hindi. Currently, there are around 10 lakh ASHA workers across the country. Some of their responsibilities include promoting nutrition, basic sanitation and hygiene practices, healthy living and working conditions, and awareness of existing health services. In recent times, their efforts have been particularly notable during the COVID-19 pandemic. ASHA workers helped in spreading awareness at the grassroots level during the pandemic. They were tasked with informing their local communities about safety protocols, tracking positive cases, and carrying out vaccination drives. ASHA workers are the first responders in situations where some people find it difficult to access healthcare services. Encouraging women to give birth under safe conditions in hospitals and medical centers is another important responsibility. ASHA workers are chosen through a process that involves community groups, self-help groups, Anganwadi institutions, block nodal officer, district nodal officer, the village health committee, and the general body of the village. The women selected undergo a series of training programs. Women from the village community who possess basic literacy skills are eligible to be trained as ASHA workers. In most cases, women from the village itself are selected as ASHA workers who operate within the local community. According to the guidelines of the National Health Mission, they are preferably between 25 and 45 years of age. Candidates who have studied up to 10th standard are preferred. The education criteria is relaxed only if no qualified person is available.
So ये जो आशा वर्कर्स की डेफिनेशंस आप देख रहे हो इज वेरी सिमिलर टू जब हमने डिस्कस करा था बांग्लादेश में स्वास्थ्य सेविका, तो उसमें एक बहुत ओआरएस स्टोरी का एग्जांपल था कि देयर वर फ्यू वुमेन जहाँ पे डायरिया वाज द लीडिंग कॉज ऑफ डेथ इन द किड्स इन बांग्लादेश. So what they did, like no technology, no medicine, nothing, they taught 100 of women how to make ORS solution. And that would just keep the kids hydrated till the time they get the first response to the medical service. And this one small simple knowledge of creating ORS at home actually saved lives of million little kids. And then no longer that diarrhea was no longer the cause of was no longer the highest cause of death in children in just few years time, and this was only because of a knowledge transfer that happened through community workers. और इसको क्या हम एक और चीज बोलते हैं, फर्स्ट रिस्पॉन्डर्स एंड ऑल्सो प्रिवेंटिव हेल्थ केयर. तो अगर आप वीडियो में देख रहे होंगे कि वो हैंड वॉश करने का प्रॉपर मेथड सिखा रही है, ठीक है. यू वुड अगेन सी इन द वीडियो कि they are teaching you about vaccination benefits. So where are these going? These are all in your preventive health care. ठीक है.
On an average, an ASHA worker earns around 6,000 to 10,000 rupees per month. This includes monthly honorarium from the central and state governments and incentives. They also receive performance-based incentives for promoting India's universal immunization program, referral and escort services for the government's reproductive and child health program, and construction of household toilets.
So I hope this is clear to all of you. So हमने health care की बात करी है. We started with the Narayana health system, and then what is like I can hear some background noise. Okay, fine. So we started with the Narayana Hridayalaya. Okay, and then we moved on to the Arvindam Eye Care. I hope that is clear. And then to the ASHA workers, and we also discussed the US healthcare system and also the Singapore healthcare system and the Germany healthcare system. So in the class, you always hear my perspective. I hope it was interesting for you to look in the videos and know where we get our material and everything from. But at the same time, it was because my throat is not well right now. It's really difficult for me to speak. But in the next class, I think we will have a 4-hour revision class. In that, we will go through the first unit. We will discuss every single PPT that we have discussed all through the course. And then I'll also ask you a few questions. So I want all of you to prepare for that particular revision class. Okay? We're done. And I don't think we will have any more offline classes, maybe 1 or 2. And let's gear up for the exams that are coming and all the very best. I think we'll have one revision class only, which will be 4 hour long. So actually 5 hours, but 2 hour, you'll get 1 hour as your break, I think. And also, while we're discussing about the US healthcare system, we've discussed about the universality थोड़ी कम है and the expense part of it. But I want you to remember कि जब हमने बात करी थी कि it spends 70% of its GDP on healthcare. So what it has is the permanent cure against the, not permanent cure, but a very strong system to deal with rare case of cancer, rare case of medical health emergencies. Okay, so R&D में or also manufacturing of vaccinations में it is still on the top. Okay, so as they said, if anybody is facing a rare case of cancer, then US is the best place. Okay, so R&D में उनका expenditure है and वहाँ पे they do in rare and cases of diseases. ठीक है? Okay, I think that is all. I wanted us to discuss about the ASA workers more in detail, but I think in that video you got clarity. In our next class, we'll discuss about the ASA workers in more clarity so that you have more understanding. और हमने international बहुत discuss कर लिया है. We have completed the syllabus. So I want you to focus on Ayushman Bharat now. I want you to focus on universal healthcare schemes around the world. We just heard about Obamacare. In the next class, I want you to go through the Obamacare. And you know now there has been a lot of changes in the process of Obamacare. तो वो सारे changes ये करके हम next class में discuss करने की कोशिश करते हैं, ठीक है? I hope that is clear. And then, okay. ठीक है, so thank you so much for tolerating. It's like really bad throat right now. So all of you take care of your health. We're studying healthcare right now here. But in the next class, we'll also focus on education part of it. Okay? Chalo, bye. Take care. Happy weekends, all of you. Bye. I'll see you next week. Okay? Make sure to be there. Thank you, Harsh. Thank you, Nishita. Okay.